Hello, everyone. We are going to have a special presentation from Dr. Ken Engelhardt. Dr. Engelhardt received his MD from Tulane University School of Medicine in New Orleans and completed his internal medicine residency at the Mayo Graduate School of Medicine in Rochester, Minnesota. He practiced internal medicine for 25 years in the private sector, mostly at the Marshfield Clinic in central Wisconsin. He then completed his career by working for 10 years at the Minneapolis VA Medical Center, where he served as the clinical chief of the section of general internal medicine. Dr. Engelhardt is a member of the Healthcare for All Minnesota Speakers Group and advocates for health justice through the Minnesota Health Plan and improved Medicare for all. He is a board member of Healthcare for All Minnesota and co-leads their Coalition Builders team. Dr. Engelhardt and his wife, Carol, live in South Minneapolis and are the grandparents of 4 grandchildren. Dr. Engelhardt.
Thank you, Judy, for the introduction. I'm going to go ahead and pull up the PowerPoint presentation for today. And let's go ahead and put it on from beginning. Here we go. So thank you all for your interest in learning more about healthcare financing in the United States. Today we'll be covering Medicare, the history, the destruction by corporate profiteers, and what you can and should do to preserve the traditional Medicare that we've all grown to love and favor and has been in effect since 1965. So let's talk a little bit about the conditions back in the bad old days before we had Medicare and Social Security. In 1913, a graduate student at Columbia University in New York City named Mabel Nassau conducted a study. And this study was done before pensions and Social Security. She looked at the living conditions of 100 elderly people in Greenwich Village in New York City. All of these 100 elderly people were poor. 27 were able to support themselves with their life savings, taking in lodgers and obtaining rent from the lodgers, or doing odd jobs such as selling newspapers. Most of these 100 elderly people were too ill or debilitated to work, though. And so this living situation called poorhouses was in existence back then, and actually had been in existence for centuries in Europe and the United States. And it was really the only place these elderly people who were too ill or debilitated to work could go to live, unless they had family that could take them in and take care of them, or if they were independently wealthy. And I kept hearing about this term from time to time growing up as a child. My parents would say, we're going to wind up in the poorhouse, and I just didn't know what they were talking about. So I learned more about this topic, about how things were before Medicare and Social Security, by reading a book that I'd recommend to you all. The name of the book is Being Mortal by Dr. Atul Gawande. Very, very, very good book. Getting back to the poorhouses, the population of people living in these poorhouses were usually elderly paupers, elderly people who were living in poverty. That was 2/3 of the population of people in the poorhouse. Also out of luck immigrants, young drunks, young alcoholics, and mentally ill people. The poorhouse conditions were really like being in prison, like being incarcerated. And the people living there were treated like inmates. They were expected to work while they were in there. And the poorhouse conditions were filthy. They were dilapidated. They were infested with rats and mice and bed bugs, and many of them did not even have a bathtub. And in 1912, the Illinois State Charities Commission report stated that these poorhouses were, quote, unfit to decently house animals, end quote. So understandably, the thought of going to a poorhouse provoked great terror in the elderly. Well, things changed during the Great Depression. There was a nationwide mass protest following the destruction of people's lives and a loss of their life savings as a result of the Depression. So in 1935, the Social Security Act was passed, and then retirement became a mass phenomenon. People could retire when they got elderly. However, the number of poorhouses did not decrease because people were still too poor and also too sick, too frail, too senile, or too debilitated to care for themselves. So in 1946, the Hill-Burton Act was passed, where a massive amount of government funds were dedicated to hospital construction. And after 2 decades, 9,000 new hospitals were built. And this was a result of improvement in medical care. Prior to World War II, there wasn't much available in medical care. And actually, hospitals were a place where people would go to die and just receive comfort care. But during and after World War II, medical care advanced considerably. Antibiotics like penicillin and sulfa came into existence. Mechanical ventilators to help support people in respiratory failure were developed, and surgeries were so much better. So medicine really took a great leap, great advancement during and after World War II, where hospitals actually then became a place where you could go and get better and actually hopefully go home. And they were no longer a place where people would go to a very sad environment and be expected to eventually just die in the hospital. So because there were so many sick and elderly people, the hospitals eventually became a place for the infirm. And in the 1950s, poorhouses closed, but hospitals then became the place where people would go, and they began to fill up with people with nowhere else to go. Then nursing homes were created to open up hospital beds. In 1965, Medicare became law, but it would only pay for facilities that met basic health and safety standards. So there were a number of hospitals, a significant number of hospitals, especially in the South, that didn't meet these health and safety standards. And because there was the fear of a backlash from Medicare patients being refused care at a local hospital, the Bureau of Health Insurance devised a term or an approval called substantial compliance, meaning, well, if you're close enough to these basic health and safety standards, we'll approve your facility. And that gave an opening to nursing homes, and there was a massive increase in nursing homes under these conditions, where 13,000 nursing homes were built by 1970. And now nursing homes are a place where about half of us will spend at least 1 year of our lives. It's not an ideal situation, but it's certainly better than the poorhouses that existed before Medicare and Social Security. This picture is a picture of the signing of Medicare into law by President Lyndon Johnson on July 30th, 1965, at the Harry S. Truman Presidential Library in Independence, Missouri. And so why is President Truman seated next to President Johnson? Well, it's because President Truman was a fierce advocate for a national health bill, but his efforts were thwarted by the AMA and others. And unfortunately, we didn't develop that national health bill that he fought for so strongly. And in this picture, you'll see next to President Truman, his wife, Bess, First Lady Bess. And they're there because they were actually the first recipients of Medicare. And Minnesotans will recognize next to Bess Truman is former Senator Hubert Humphrey, Vice President. And also next to Lyndon Johnson, you see Lady Bird Johnson in this photo. So the history of Medicare, before we had Medicare, about 60% of people who were older than age 65 had health insurance. But older adults paid more than 3 times for health insurance than younger people. In 1966, provider payments became conditional on desegregation. So this is a little known history about Medicare, and Medicare actually helped facilitate desegregation. So because in 1966, provider payments were made conditional on desegregation, thousands of waiting rooms, hospital floors, physician practices became racially integrated. In 1972, benefits for speech, physical therapy, and chiropractic treatments were approved for Medicare patients. In the 1970s, however, things began to take a turn for the worse, where this term managed care came into existence, leaving open the option of payments to health maintenance organizations, HMOs. And this payment to HMOs was formalized and expanded as Medicare Part C under President Clinton in 1997, named Medicare Plus Choice in those days. And in 2003, the name of that program was changed to Medicare Advantage. In 1982, hospice benefits were added to Medicare. In 2001, coverage for younger people with ALS, Lou Gehrig's disease, was added. And then later, benefits to younger people receiving Social Security disability insurance and patients with end-stage renal disease was approved. And in 2003, under President George W. Bush, Medicare Part D was approved into law. Medicare was first administered by the Social Security Administration, and now it's administered by the Centers for Medicare and Medicaid Services, known as CMS. In 2018, about 60 million people had Medicare, and more than 52 million of those people were older or at age 65. Medicare doesn't cover all expenses, and that's why we advocate for new and improved and expanded Medicare. A lot has happened since 1965, and it needs to be updated, and that's what we're advocating for. Medicare does cover about half of the expenses, and the rest is covered by supplemental plans by most people, and joining Medicare Part C or D to help them cover the rest of the expenses. So the out-of-pocket expenses for Medicare are deductibles, copays, long-term care, dental, vision, hearing, and annual exams. Under the Jayapal bill in the House of Representatives, these things are covered. There's no deductibles, no copays. Long-term care is provided for under the new Medicare bill in Congress, and dental, vision, and hearing is provided, as well as annual exams. So these things that aren't in current Medicare are incorporated into the bill that's before Congress now, and it's the Jayapal bill. There are numerous funding sources for Medicare, such as payroll taxes, beneficiary premiums and surtaxes, copays and deductibles, and then also general U.S. Treasury revenue. There are 4 parts to Medicare. Part A, when we talk about Part A, just think of hospital care. It's inpatient care. So it covers inpatient admissions. It covers non-custodial care to skilled nursing facilities after the patient has spent at least 3 days in the hospital, but it's not intended for living the rest of your life in that skilled nursing facility. You'd be expected to be able to go home after a period of rehab. And Part A also covers hospice. The second part of Medicare is Part B, which deals with outpatient. So think of clinics. So Part B covers outpatient services. It does cover some provider services while inpatient. So you may go to the hospital and be an inpatient for surgery. That would all be paid for under Part A, but the surgeon services may be paid for by Part B. Part B also covers outpatient hospital charges and provider visits in a hospital setting, but these are not admissions. These are care delivered as a hospital outpatient. And Part B also covers most professionally administered prescription drugs, medications that your medical team is giving to you. These last two parts of Medicare have been problematic. Part C, think managed care, think HMOs. It came into full fruition in 1997 during the Clinton administration. In order to qualify for Part C Medicare, you must be enrolled in Parts A and B. We now know the managed care part of Medicare as being Medicare Advantage. That's the name for it these days. And patients who select Medicare Advantage are allowed to choose a plan with it that has at least the same coverage benefits as Medicare A and B, and oftentimes Part D, which is prescription drug benefits. And there's always an out-of-pocket expense limit under Medicare Advantage, where under Medicare A and B, there is actually no out-of-pocket limit. There is under Medicare Advantage, however. And with Medicare Advantage, patients can elect to choose Medicare Advantage. They're not put in a situation where they're forced to accept Medicare Advantage, and that will be important as we continue on with this talk. And then finally, there's Medicare Part D, which covers prescription drugs. It was approved in 2003 under the George W. Bush administration, and it covers almost all self-administered prescription drugs, medications that you take yourself that aren't given to you by your medical team. Part D has the problematic part of prohibiting Medicare from negotiating drug prices. That was part of the bill for Part D Medicare, and that is definitely a problem. So there are both good and bad parts to Medicare Part D. So let's talk about Medicare financing. In 2018, Medicare spent more than $740 billion for care, and that was 15% of US federal spending and about 3.7% of GDP. And you can see now what's happening as a result of baby boomer retirements. In 2026, the projection is that spending is going to increase to $1.2 trillion and be 4.7% of GDP. In 2030, the enrollment in Medicare is expected to be over 80 million people. As you recall from a slide or two back, there are currently about 60 million people in Medicare. So by 2030, that's expected to rise to more than 80 million people. In 2043, spending is projected to be 6% of GDP, according to the 2019 Medicare Trustees Report. And in 2093, spending is expected to be 6.5% of GDP. So in response to these financial challenges, significant cuts to acute care hospitals and skilled nursing facilities were made in 2010 in the Patient Protection and Affordable Care Act, otherwise known as Obamacare, and in another act called MACRA in the year 2015. So we'll talk about Medicare Advantage at this point. There's kind of a fallacy that we can control these costs that we just saw in the last slide by inserting a middleman to supposedly limit the costs and keep things affordable. But the middleman really is an entity that is there to maximize profits for themselves. So how does inserting a middleman whose main interest is making the most profit possible going to help with controlling costs? It really doesn't make any sense, but that's still the ongoing belief in Washington, D.C. these days. So under Medicare Advantage, Medicare pays a managed care middleman, usually a private insurance company, instead of directly paying providers. And in 2021, the Kaiser Family Foundation found more than 26 million people were enrolled in Medicare Advantage, or you could think of it as being 42% of the total Medicare population was enrolled in Medicare Advantage in that year. Now, taxpayers pay $321 a year more to cover a Medicare Advantage senior compared to a senior who is receiving traditional Medicare. So Medicare Advantage is more expensive. And when you take that $321 a year and multiply it by 26 million people, that's a lot of taxpayer dollars. The annual gross profit margin for Medicare Advantage plans is a profit of $1,608 a year per enrollee between the years 2016 and 2018. So it is a costlier program, and it results in profits for these insurance companies, and actually ends up costing taxpayers more money. So let's talk about Medicare direct contracting and reach. This diagram shows what happens under traditional Medicare, where the United States government directly pays your doctor, your provider, for the medical care you receive. It's very simple. There's no middleman involved. It's a direct payment to your doctor. This slide, currently projected, shows what happens under Medicare Advantage. So instead of the US government paying your doctor directly, they pay a middleman, usually an insurance company, who then keeps a percentage of the profit for themselves and pays your provider for the care that you receive. So there's a middleman there taking a portion of the taxpayer dollars that are designed to provide Medicare for you. And the latest version of this privatization scheme is called direct contracting. Many people haven't heard of direct contracting. It was developed by the Center for Medicare and Medicaid Services Innovation, CMMI, which is an obscure agency within the Health and Human Services Department that has the power to implement pilot programs, trial programs, and then scale them up, but without congressional approval. They can just do that on their own. So this shows direct contracting, which is the next stage beyond Medicare Advantage. Once again, you see the federal government making payments. They make the payments to a middleman, but above the middleman, you see these other people with money bags beside them. They are the investors who are see an opportunity to gain profit with direct contracting. So they're funding the middlemen to promote direct contracting, get people signed up for direct contracting so that they can make a profit. So you have the middleman there wanting to make a profit. And then you also have the private investors supervising and funding the middleman. So there's a lot of effort here now to make money off of the Medicare system. And once again, the middleman ends up paying your provider for the care that you receive. So direct contracting currently has programs running. There are 99 direct contracting entities in our nation right now. And virtually any type of company can apply to be a direct contracting or reach, as it's also called, middleman. So it can be a commercial insurer, it can be a Wall Street private equity investor, and applicants to become a direct contracting entity, DCE, are approved without any input from Congress. It just happens under Medicare. So the timeline, the history of this was that in 2019 to 2020, under the Trump administration, the development of Medicare direct contracting came into existence and was launched in April of 2021. This was a rather stealth program. Not many people knew about it, but groups like Physicians for a National Health Program found out about this privatization scheme. And in 2021 through early 2022, a grassroots campaign emerged to stop this privatization of Medicare through direct contracting. This pressure campaign resulted in the change in the name of Medicare direct contracting to a program called REACH in February of 2022. But unfortunately, it was just a change in name only, and many of the bad features of direct contracting are still in the REACH program. So in April 2021, the direct contracting entity program was launched. The pilot was launched with 53 DCEs, 53 entities present at that time. A few months later, this past January, there were 99 direct contracting entities. And the goal is to enroll 1.8 million new enrollees this year. The ultimate goal is to have all of traditional Medicare patients in a DCE by 2030. So in just a few short years, Medicare as we know it now will no longer be in existence. Instead, the plan is to have it fully privatized by 2030. There's been a quiet explosion of Wall Street investors buying up primary care practices, family practice doctors, internal medicine doctors, buying up their practices because they see potential massive profits over time under this privatization scheme. But as I mentioned before, there's been a grassroots movement to fight back, to push back against this Medicare direct contracting program. The end of November of 2021, physicians and other activist groups, labor organizations, patient advocate groups delivered a petition with over 13,000 signatures to Secretary Becerra, Secretary of Health and Human Services, who oversees the Medicare program. And these same advocates met with members of Congress. And they were very surprised to find out that the members of Congress didn't even know that this direct contracting program was occurring. In January 2022, over 50 members of Congress signed a letter demanding that direct contracting privatization come to an end. Now, the only Minnesota member of Congress who has signed that letter is Representative Ilhan Omar. The other representatives from Minnesota have not yet signed on to the letter. In February 2022, Senator Elizabeth Warren spoke out in a Senate hearing about direct contracting and the privatization of Medicare. And the president of Physicians for a National Health Program, Dr. Susan Rogers, testified at that hearing. Now you'll see Dr. Susan Rogers in this picture with the black derby hat on her head. She is the the president of Physicians for a National Health Program who testified at that hearing. And there's also been dozens of articles, op-eds and letters, calls to Congress protesting this privatization program. So REACH actually threatens Medicare solvency. REACH middlemen may spend as little as 60% of Medicare revenue on actual patient care, and they're allowed to keep up to 40% for their own profits. So these three pie charts show first traditional Medicare to the left, where 98% of taxpayer dollars goes to patient care, and only 2% is used for overhead. The next middle pie chart shows what happens with Medicare Advantage, where overhead and profit under Medicare Advantage takes 15% of taxpayer dollars, leaving 85% of taxpayer dollars to pay for actual patient care. And then the third pie chart shows what happens under the direct contracting or REACH program, where only 60% of taxpayer dollars is spent on patient care, and the remaining 40% can be spent on overhead and profit. And that's why you see these private equity firms rushing to take over traditional Medicare. So how do direct contracting REACH middlemen make money for their investors? Well, there's three ways. One is to increase the money coming in from Medicare. In other words, they code your diagnoses high. They decrease the money that they actually spend on medical care, which means they treat low. And they also increase volume through enrollment. This is an example of what's called upcoding. Each one of us in the Medicare program has what you could say is a price on our head. We have a risk assessment, and under the typical coding program, the chart to your left, there is a patient with the various conditions listed, and the risk score comes up to 1.03 for a total. And what happens then is Medicare pays what your projected costs are supposed to be for the year with that risk score. So that patient has a risk score of 1.03 and results in $9,000 being paid to the REACH middlemen for the expected care of that patient. Now that's just a projection. It isn't actually the care that that patient receives. The chart to the right shows what happens with upcoding, and I'm going to use the example of asthma being upcoded to what's called COPD. The way doctors would diagnose asthma is just call it what it is, namely asthma. It's a disease that flares up intermittently, but it's not constantly present usually. It's episodic, and it's an inflammation of the airways manifested by shortness of breath and wheezing. But this particular patient, the 76-year-old female in the chart to the left, ends up with a 0 in her risk score from asthma. But by upcoding, if you change asthma to the diagnosis of COPD, you see the risk score increases from 0 to 0.328. And this has a great deal to do with increasing the total risk score, along with other upcoding examples provided, to a total risk score for that patient now of 3.63 instead of 1.03. That results in the payment to the Medicare middleman of $32,000 for that year instead of the original $9,000. So you can see what happens with upcoding. It makes patients look sicker than they really are, so that the middlemen can be paid more per person per year by Medicare. So upcoding by Medicare Advantage and direct contracting entities. Risk scores of Medicare Advantage patients are 19% higher than under traditional Medicare. And Medicare overpays Medicare Advantage insurers. They paid more than $106 billion in overpayments from 2010 through 2019. Capitation is a term that we've basically covered, where it's a certain amount paid to the Medicare Advantage insurer per enrollee based on enrollee risk score. So each person in Medicare has a risk score, and based on the risk score, that capitated dollar amount is paid to the middleman every year by Medicare. Now, capitation and risk scores, as I mentioned previously, are really not the care you've received. They are simply projections, estimates of what your care might cost in the next year. So how do these Medicare Advantage and direct contracting entity people operate to upcode? Well, they have sophisticated software to scan for upcoding opportunities. They pay doctors to add diagnoses to your chart. They send nurses to your home to talk with you and see if there's any opportunity at all for upcoding. And they actually buy provider practices to control the coding process. The second way they make money is to minimize revenues spent on care. In other words, to ration your care. So direct contracting and REACH middlemen are allowed to keep as profit and overhead what they don't spend on medical services, creating a dangerous incentive to ration care and restrict seniors' care. These financial incentives do not exist in traditional Medicare. What are the ways that they avoid making payments? Well, one is cherry picking. In other words, they aggressively market to have healthier seniors sign up for their program and try to avoid having the sicker patients join their direct contracting entity or Medicare Advantage. Another way to avoid payment is through the pre-authorization and denial program, denying care that your doctor thinks that you need, requiring your doctor to go through a pre-authorization process and kind of a captain, may I order this test or give this treatment to this patient, the final decider being the insurance company. They also avoid payments by having a narrow network of specialists, so you can't actually go to whatever specialist you want to see. You have to go to the specialist that the insurance company has selected for you. And then finally, another way to avoid payments is to have hidden costs for costlier care, such as the cost of receiving chemotherapy. So the above barriers often force Medicare Advantage enrollees to switch back to traditional Medicare when costly or complex care is needed, especially in the last year of life. And the third way that they make money is to increase volume through enrollment. Asking seniors to change primary care physician undermines traditional Medicare's promise of free choice of provider. But that's exactly what is happening with the direct contracting entity program. The only way you can get out of the direct contracting entity, if your doctor, primary care doctor, is part of that DCE, the only way to get out of it is to switch to another primary care provider who is outside of the DCE. Here is a letter received by an actual patient in the metro area from the Fairview Health System. Now, the Fairview Health System is one of the systems that has a DCE. I know Health Partners in Park Nicollet does also, and there are others. There are some concerning things about this letter. If you'll note in boldface type, the second paragraph, it states, your provider asked Fairview Health Services to help see that you get the right care at the right time. So they're basically blaming your provider for the Fairview Health System making the decision to become a DCE. My suspicion as a former internal medicine provider is that the doctors in the Fairview Health Services system were not polled and asked if they were wanting to join a DCE. They were just simply told they're now part of a DCE. So I don't think the doctors really had much input in that decision by Fairview to become a DCE. The other part that concerns me is in one of the last paragraphs there, the one just before questions, and it states, your Medicare benefits have not changed, and that is not true. If the direct contracting entity has a restrictive network, you're not allowed to see any doctor or go to any clinic or hospital of your choosing. You're under the restrictions of the network provided by the insurance company. So direct contracting entities are a threat to Medicare's future. They threaten Medicare's solvency. And while traditional Medicare spends 98% of its budget on direct care, direct contracting and reach middlemen can spend as little as 60% of what Medicare pays them on profit, or less than 60% on patient care, and keeping 40% for overhead and profit. And I should also tell you that under Medicare Advantage, patients chose to join Medicare Advantage. But under this new program of direct contracting and reach, you don't have any choice. If you have a primary care provider that you've seen in the last 2 years who's part of a direct contracting entity, then you're automatically enrolled with, oftentimes without your knowledge or consent, automatically enrolled in that DCE program. You really don't have a choice if your doctor, your primary care provider works for that healthcare system, such as Fairview or Health Partners, Park Nicollet. So in summary, the DCE is a dangerously flawed model. It radically transforms Medicare. It undermines seniors' choices. It incentivizes harmful restrictions on patient care. It incentivizes fraudulent diagnostic coding by upcoding. It threatens to bankrupt Medicare. And it avoids Congress. Oftentimes, as I mentioned before, congressmen don't even know that this direct contracting entity program is ongoing. And by avoiding Congress, it undermines the democratic process. So we have a choice. You know, we can just sit back and let Medicare become fully privatized by 2030 by doing nothing. that it's going to happen. We see the number of DCEs that have increased. But really, if we want to keep traditional Medicare and what it was designed to do, we really should act. And these actions take very little time. Each phone call is 2 minutes maximum usually. The first call you can make is to President Biden. You might want to take out your cell phones, take a picture of this slide. The telephone number to call President Biden is listed, and you can make that call from 11 to 3 Eastern Time, Tuesday through Thursday. Just simply leave a message saying you want President Biden to end direct contracting and reach today through executive action. The other calls you can make is to your U.S. representative and to your 2 U.S. senators, simply by calling the U.S. Capitol switchboard. The number is listed there for you. The operator will connect you with a staffer for, say, Senator Smith or Senator Klobuchar or your U.S. representative. When you speak with that staffer, tell them that you're a constituent of the representative or the senator, and demand that that representative or senator join the fight against direct contracting and reach to end that privatization program that you want to keep Medicare as traditional Medicare. And then finally, you can copy and paste that link there listed in blue print. Just copy and paste that and sign that petition from Physicians for a National Health Program to end the direct contracting and reach program. When you go to sign that petition, it'll ask you what type of individual you are. Are you a physician? Are you in the medical field? And there's a choice that you're just a healthcare advocate. You can just state that. You can choose that choice. You don't have to worry about saying you're a medical professional of some sort. But just copy and paste that and sign the petition. Those 3 steps, very little time involved. As I mentioned, each phone call is about 2 minutes, and it's well worth your time if you really want to keep Medicare under a public program through the U.S. government instead of being privatized for profit by these various Wall Street entities and insurance companies. So this is the end of my talk, and I thank you very much for your attention. It's been a pleasure learning about this and sharing this information with you. I wish you all a good day. Thank you.